Please go ahead. I don't think I need to say anything about Dr. Hiremath. He's well known to all and everybody. I consider him as one of my teachers. So please, Dr. Hiremath, go ahead with your presentation.
Good afternoon, everybody. And we are now going to look at OCT in the calcified region. I would feel OCT's biggest advantage is in the assessment of calcium, because calcium, as we know, has a big issue in the results, short term as well as long term. So if you have a heavily calcified artery, the results are here, while if you have mild to moderate calcium, the results are far better. So this is how a stent would fail to expand. You know, if you're not prepared the bed, and you once you got your stent through and unable to expand, it's a big issue. What happens when you have incomplete expansion of the stent? Your stent is away from the vessel wall, so the drug elution into the vessel wall is incomplete. So you would probably have more ISR, and if not, an acute stent issues. So when you see calcium, whichever way you try to image, the arc of calcium, the length of the calcification and thickness of the calcium, if these are high, greater is the likelihood of stent under expansion. So you need to assess all these arc, length, and the thickness. And this is where the importance of OCT comes in. In this particular study, the stent thrombosis after PCI was much higher because the stents were underexpanded. And as I told you, if stent thrombosis is an immediate sequelae, and ISR is a later sequelae if the stent is not well expanded. Let's see how we can image and see the comparison between various imaging modality. Most of the time, the CT angio is ignored. The radiology department reports, and the cardiologist is only interested in finding out if there is some lesion, and then he wants to take the patient to cath lab. But whenever you want to think of calcification, do take a look at the CT angio. So it can tell you the calcium location and also spotty calcification, which is not seen on the conventional catheter angiogram. When you talk about the catheter angiogram, you get an outline of calcium. Now, we cannot sort of decide whether the calcium is outside along the adventitia or inside, and thus cannot make a decision whether we need to do some kind of extra steps to handle the calcium. So the sensitivity of a conventional catheter angiogram is low. For years, we used IVUS, and you see a nice round calcification like this. So IVUS is easy to pick up, actually. No contrast during IVUS. So this is an advantage of IVUS over OCT. However, microcalcifications are not easily detected on IVUS. But in general, before OCT, it was always an IVUS which helped us to decide. Now, when we talk of OCT, there are maximum advantages that you have a very high resolution, calcium thickness can be easily accessed, then quantitative grading of the calcium. I mean, you can talk about the localization, thickness, area, and volume. And microcalcification, which can sometimes be responsible for balloon rupture and so on, are also seen on the OCT. So all these are extremely important when you plan PCI in a calcified vessel. The disadvantage is, of course, the contrast media. I would feel most of the time calcified vessels are with CKD or borderline CKD. and contrast media is an issue. Also, the penetration of the OCT deep towards adventitia is limited, and that's why you may not be able to see it all the way to the adventitia. So this is how an OCT would look with calcification. And OCT is actually a great guide to decide where is your calcium located. Like if you are going to end your stent at a particular spot here, let's say, and you see calcification here, maybe you should extend your stent length to cover that particular portion. OCT, of course, and again, very useful post stenting to decide if the stent has expanded fully well. So there are lots and lots of issues which can be sorted out. In fact, following stent placement, if you see a particular area not expanded and you see lots of calcium behind, there could be still some options available to you today to go in and correct the under expansion then and there. Never leave an under expanded stent. So this is how the imaging comparison would go between conventional angiogram, very poor for calcification, CT far informative, IVUS, including the virtual histology, giving you a lot more information about the quality of plaque. And of course, OCT is master of all, showing you classification very adequately. Now, why is it required to do it? We have options like we do with balloon and modified balloons, like a cutting balloon and today the OPN balloon. Then we have options like the rotablator, laser, and finally today we have an IVL. So all these choices can be made based on where is your calcification. These are actually simple to use techniques for calcification: the lithotripsy, cutting or scoring balloon, and ultra high pressure, the OPN balloon. So these are all balloon based, and you do not need too much of learning for usage of these, though everything will have its own few peculiarities. The bifurcation lesion, where you have calcification, the lithotripsy balloon IVL worked very well. Like in this case, before lithotripsy was available, you have extensive calcium at a very important bifurcation between LAD and diagonal. So we did a rotablator to the LAD and did a flextome balloon towards the side branch diagonal, because we did not want to withdraw the rotablator wire once you have done a rota. So this is how we used to do bifurcation. But today, when you have a bifurcation lesion, like in this case, you have a critical left main bifurcation. This particular lady had lots of issues: poor ventricle, severe obesity, OSA, and that's why we started with a balloon straight away. You put two wires. So in the previous case, you saw we had to use one rota and one scoring balloon, but here you are using IVL lithotripsy towards circumflex, then in the left main, and then towards LAD. So the wires are where they are. You got rid of your calcium, so you're quite sure your stent is going to expand. And this is how we ended on this particular case. The lithotripsy balloon is a bulky balloon. And so many times, in addition to the guide catheter, which may be giving a good support, you may have to use guide catheter extension in form of guidezilla or guide liner to get the lithotripsy balloon down. When you compare the three sort of difficult to learn or long learning curves procedures, the rotational, the orbital atherectomy and the excimer laser, you realize that with rotational, you can have plaque modification, but you still need something more to get a stent expansion. The excimer can have, if the lesion is hard to cross, like CTO, the excimer can be very good. In fact, if you have ISR with a CTO, excimer would work very well. We all know that for rotational, we do pecking movements. The downside would be slow flow or no flow. This doesn't happen every time, but like in this case, there is no option but to do a rota as your first option. So when you do a rota, in this particular case, we had slow flows, ST elevation, so we had a prolonged wait. However, most of the time, these things settle with good dilators, and we could see good flows into the distal portion. This patient, in fact, had calcified vessel. This is one dictum I always follow, that if you have one vessel which is calcified, the others are also very likely to be calcified. We're able to address the LAD with ultra high pressure balloon, and this was a good result. But this may not be same every time. Like in this case, this gentleman had an ACS, so we waited actually 15 days on low molecular weight heparin because we had a combination of calcification as well as thrombus. And ultimately, since the vessel diameter was small, we had to use rotablator, and we had slow flows, which took a long time to recover. This was also a very important vessel because it was giving collateral to the RCA. When you compare the 3 or 4 options which are available to us, the OPNNC balloon, we'll talk about this a little bit later, but especially when you have a small lumen, you want to increase the lumen or get more things inside, like OPN balloon or an IVL balloon, you probably need to do rotablator. Cutting balloon is very good for ISR, and IVL, as you can see the options, it is extremely good for decalcification. So this is a case which was actually done outside, and this was the picture that the balloon was not expanding. So in our case, we did this just to make sure that a regular balloon is not expanding. Never go on high pressure because you're probably pushing off your option of rotablator. So after rotablator, you can see the expansion is so easy. And so this is again a combination of rotablator followed by non-compliant balloon, and then plots to get this kind of results. So this was a case, again, had an ACS, we kept a long gap. On this particular case, we did an IVUS, and this was a calcified vessel as well as thrombus. So we decided not to do rota and opted for an OPN balloon going towards LAD and circumflex. And then finally, a good result with 2 stents at the bifurcation location. What was previously a rota followed by stent is today for internal calcification, you do rota, make space, and bring in an IVL. So rotatripsy could be an option. We are now talking of combination techniques, and these combination techniques could be decided on what you see on imaging. So it is rota followed by an OPN, rota followed by an IVL, IVL with OPN combination, and then cutting scoring balloon with OPN balloons. So all these are clearly decided based on what we see on imaging. The IVL and OPNNC are the two new innovations to comprehend the age-old but risky and tricky rota to work in tandem to tackle the calcium, which has always been a difficult issue. In OPN, you have two layers of balloon, and that's why you don't get dog boning, which is one of the problems with the conventional balloon. So the expansion is very uniform throughout. Possibility of rupture is not there. This is how the regular balloons expand. If you start going on higher pressures beyond 10 and 12, they expand in diameter. And this is what happened. This was a focal lesion, and a non-compliant balloon results into a dissection, which is going a long way. So instead of sort of ending up with a short stent, 18 millimeters here, we ended up with 34 millimeter long stent in this particular case. So the dog boning will result into a dissection on either side. And this is how the OPN balloon goes. Even if the pressures are increased to say 35, the balloon does not expand too much. The high pressures like 40, 45, sometimes the balloon sticks to the wire. And especially if your wiring has been difficult, while pulling out the OPN balloon, it pulls out the wire. So sometimes if I feel resistance while coming out, I put an additional wire, a buddy wire on the side. So even if your original wire comes out because it is sticking to the OPN balloon, you have a wire on the side. So this is just a precaution. It is not the balloon diameter, but it is the pressure that you use on OPN. So for bed preparation, maybe you go one quarter size or half size down. There are no quarter sizes. So half size down, go very high on pressure. While post-stent, you can go 1-to-1 and go high pressure for a fuller expansion. And these are some of the sort of algorithms that we use. If your conventional balloon is showing a good expansion, I think you can possibly go ahead without rotablator. Like this was a very 10-year-old CTO and very well collateralized, but you can see calcium here. And this calcification was actually worrying. So we thought we were all ready with rotablator and possible IVL. But here the PTO wire has gone across, but the balloons were not going. We had everything to support like long sheet, a big diameter catheter. And then we use this balloon NIC Nano Hydro, which is 0.85 with a short length. And this balloon crossed through with support with the guideliner. So this is what we used. After that, we did an IVUS, which showed that calcification was mostly adventitial. So this case was then done with OPN balloon, and you can see
sorry.
a good expansion. So these are the kind of algorithms that we use. So you can take, if you're not doing imaging, you can take a feel with a conventional balloon. Don't try to stretch, but if the balloon is not expanding, which would be the reason in most of the cases, you can switch to planning, which is sort of specific for calcium. So you can choose a rotablator with OPN or rotablator with lithotripsy and whatever. So calcification is interventionist arch enemy. Imaging really, really helps you to decide what is going to be your best option. If you don't end up with a nice expansion, we are likely to expect trouble in the immediate hospital stay, or later, a few months later, with an ISR. Thank you for your attention. Let's go to the chat box. There's some questions in the chat box. No, I don't see any questions unless the moderators feel there are some questions. Yeah, there is one question. ACS with calcium and thrombus, wouldn't be shockwave better than rota if IVL balloon can pass? Yes, certainly. I think I actually showed you one case where we used an IVL where we had an ACS, and that's why we didn't do rota at the left main bifurcation. So I would entirely agree that if you have both calcium plus thrombus, I think IVL could be a better option, provided it can go through.
Good, Shirish. At the end is another slot for questions. So maybe we'll have more questions that time.
Okay.
Thank you.